How do you determine whether T-wave inversions are persistent juvenile T-wave inversions or if they are ischemic T-wave inversions? This can be really challenging to determine when you're rapidly reviewing ECGs in the emergency department, and it's important because T-wave inversions, especially in those anterior leads, can signify a number of different pathologies, including ischemic changes, Brugada, arrhythmogenic right ventricular cardiomyopathy, as well as RVH with strain, as you would see in a pulmonary embolism. Rule number one is to assume that those T-wave inversions are pathologic in nature because you don't want to call something benign that is actually quite dangerous. There are three tips that we can consider to determine if, in fact, they are persistent juvenile T-wave inversions. The first thing to look for is that juvenile T-wave inversions are usually asymmetric. If those T-wave inversions are symmetric, you should assume that they are ischemic T-waves. Number two is that juvenile T-wave inversions are usually 3 millimeters or less in depth. And then finally, number three is that persistent juvenile T-waves are typically going to be present in V1, 2, and 3, and not so much in V4, 5, and 6. If we keep those three things in mind, asymmetric T-wave inversions, typically seen in V1, 2, and 3, and less than 3 millimeters in depth, we're more likely to identify juvenile T-wave inversions when they're there, as opposed to mistaking them when they're actually ischemic T-wave inversions.